So good evening, everyone. I think we'll get started. I want to welcome everyone to this symposium on harnessing novel synergies with tumor treating fields. And of course, thank PeerView for having us to lead this symposium. Tonight's panelists will be myself, Eric Sulman. We have Dr. Zachary Horne and Dr. Rupesh Kotecha. Again, thank you to PeerView for providing this session. And for those joining us in person tonight, please answer the polling questions at the beginning of this activity using your keypads that you have right in front of you on the table. And those who joined virtually already have done the pre-event survey. There'll be additional polling questions as we go through the talks, and then you'll have an opportunity to submit answers at that time. And then if you have individual questions, we're going to have a QA at the end, and we welcome your questions for the QA session. You can go to this link to get slides as well as practice aids. You can get them now, and they'll be available after the event as well. There's an email here live at peerview.com if you have any need for further information, and social media links as well. Okay, so our first polling question, not too challenging. Please select your degree or profession. I was told to read the answers. These are a lot, so MD or DO, PhD, PharmD, BS in Pharmacy, RN, NP, PA, physicist, dosimetrist, radiation therapist, or of course other. So please enter your response. There's a little timer on the bottom right of the screen that will tell you when these responses will no longer be available. Excellent. Okay, question 2, please select your specialty or role. So number 1, radiation oncology. Number 2, medical oncology. Number 3, neuro-oncology. Number 4, non-clinical research. Number 5, non-clinical industry. Number 6, patient, caregiver, or advocate. And number 7, other. Here's your little Jeopardy countdown here. Excellent. And question number 3, in the care of how many patients with solid tumors are you involved each month? 0, 1 to 10, 11 to 20, 21 to 30, 31 to 40, greater than 40, or not applicable. Okay, so now perhaps some additional challenging questions here. Okay, so for the first baseline polling question, which of the following has been demonstrated with use of tumor treating fields in the treatment of patients with glioblastoma? Number 1, I don't know or I'm not sure. Number 2, software generated treatment mapping that increases TT fields dose delivery at the tumor bed is associated with an OS benefit. Number 3, older patients greater than or equal to 65 years derive less OS benefit from TT fields than younger patients less than 65 years. Number 4, only patients who use TT fields greater than or equal to 18 hours a day, i.e. greater than or equal to 75% compliance, realize an OS benefit. Number 5, TT fields frequency is directly proportional to cancer cell size, i.e. higher frequency affects larger cells. Please make your selection. Great. Okay, so question 2. Which of the following is true about effective management of dermatologic events that may be caused by TT fields arrays placed on the shaved scalp? Number 1, I don't know or I'm not sure. Number 2, petroleum-based ointments should be applied since they will not affect TT fields' electrical impedance. Number 3, treatment e.g. topical corticosteroids or topical antibiotics, should be based on type and severity of the adverse event and applied at the time of array changes and shifts. Number 4, water-based lotions, soaps, foams, and solutions should be avoided due to their increased impact on electrical impedance. Number 5, prophylactic measures, e.g. optimal shaving, array positioning to decrease risk and severity of dermatologic AEs, have proven ineffective. Question number 3. How would you treat an 84-year-old man with newly diagnosed, medically inoperable and unresectable malignant pleural mesothelioma? Assume epithelioid histology and good performance status. Number 1, I don't know, I'm not sure. Number 2, neoadjuvant chemo and pleurectomy decortication. Number 3, pemetrexed and cisplatin. Number 4, platinum-based chemo plus radiation therapy. Number 5, pemetrexed, carboplatin plus concurrent TT Fields therapy. Number 4, can you identify which patients have been randomized to receive the combination of TT Fields and standard of care therapy in the phase 3 LUNAR trial? Number 1, I don't know, I'm not sure. Number 2, patients with newly diagnosed stage 4 non-small cell lung carcinoma. Number 3, patients with stage 4 non-small cell lung carcinoma progressing on platinum therapy. Number 4, patients with stage 4 EGFR mutated non-small cell lung carcinoma progressing on prior therapy. Number 5, patients with stage 4 non-small cell lung carcinoma progressing after multiple lines of prior therapy, including chemotherapy and checkpoint inhibitors. Number 5, which first-line treatment strategy is being tested in the EF31 trial with GE junction or gastric adenocarcinoma? Number 1, I'm not sure which treatment strategy is being tested in EF31. Number 2, TT Fields plus standard of care chemotherapy plus trastuzumab for HER2-positive patients only. Number 3, TT Fields alone. Number 4, TT Fields plus immune checkpoint inhibition. Number 5, TT Fields following surgical resection. Number 6, how likely are you to consider referring eligible patients with GI, thoracic, or gynecologic cancers to clinical trials testing novel multimodal treatment options such as tumor treating fields? Number 1, I typically do not refer patients to clinical trials testing multimodal treatment options. Number 2, unlikely. Number 3, somewhat likely. Number 4, likely. Number 5, I am very likely to refer patients to clinical trials testing multimodal treatment options. Number 6, not applicable. Okay, so that is it for our questions. We'll revisit these questions as we move throughout the talks. So tumor treating fields is a new cancer modality, new going back to the first clinical trial in 2004, which was a pilot trial of glioblastoma, the EF07 trial. In 2011, tumor treating fields were approved for recurrent glioblastoma after the EF11 trial. In 2015, tumor treating fields were approved for newly diagnosed glioblastoma after the EF14 trial. Subsequently, only a few years ago in 2019, they were approved for unresectable MPM and many trials ongoing in solid tumors. We're now going to go through some of the data for each of these indications as well as what is ongoing in development in clinical trials currently. So despite advancements in the use of tumor treating fields, the clinical applications, the clinical adoption of it has actually remained quite low. In patients with glioblastoma, the first indication, Tumor Treating Fields is used only in around 10% of those with newly diagnosed disease, and even lower number with those with recurrent disease. So we're going to address best practices for overcoming the challenges and barriers to prescribing Tumor Treating Fields for patients with glioblastoma or MPM, and preparing to implement novel multimodal strategies in other aggressive cancers. So, the primary mechanism of Tumor Treating Fields are antimitotic therapy. Living cells contain ions and polar or charged molecules. These charged particles and dipoles are influenced by electric fields. In TT fields, the electric fields are alternated very rapidly at high frequency, and they disrupt the charged particles during mitosis. This leads to cell death as dividing cells try to divide, but it spares quiescent cells and most normal cells as a result. You can see that the role of TT fields is at that cytokinesis stage when the daughter cells are being split off from the original cell. Whoop, I thought we were watching a short video.
In metaphase of cell division, cells are a rounded shape as the mitotic spindle forms. Intracellular components such as macromolecules and organelles are naturally charged. Tumor treating fields, or TT fields, disrupt cancer cell division by physically interacting with molecules required for mitosis. When alternating electric fields are applied to cancer cells, they disrupt microtubule polymerization. Tubulin dimers align with the electric field and are not able to form microtubules. This prevents the organized assembly of the mitotic spindle required for normal cell division. The inhibition of microtubule formation leads to metaphase arrest and cancer cell death. In addition, these deformed microtubules can lead to abnormal DNA segregation between daughter cells, which also results in cancer cell death. TT fields can also affect cells after metaphase. If a cancer cell has passed metaphase and enters the cytokinesis phase, the cell takes on an hourglass shape. This state under TT fields creates a non-uniform electric field inside the cell, creating dielectrophoresis. Net forces push the macromolecules and organelles toward the mitotic furrow, and this disruption leads to structural disorganization and cancer cell death. Transducer arrays can be placed on the scalp, chest, or torso to deliver TT fields that kill cancer cells. The placement of transducer arrays is personalized for each patient.
Okay, so when we think of how TT fields are used to treat cancer cells, it turns out that there is a particular frequency depending on the specific cell. And what you see first is that normal cells, like the normal intestine, have a much lower frequency, 50 kilohertz, than the cancer cells of various types. And you can see there's quite a variation. So glioblastoma, GBM, is at 200 kilohertz, mesothelioma at 150 kilohertz, breast at 120 kilohertz, and so on. For the ongoing trials, it's worth noting that non-small cell is also at 150 kilohertz. The key takeaway is that the effect of frequency is inversely related to cell size. So on today's seminar, today's agenda, I will be talking about tumor treating fields in glioblastoma. Then Dr. Kotecha is going to talk about treatment in mesothelioma, but also other thoracic cancers that are undergoing active clinical trial with TT fields. And then Dr. Horne is going to talk about extending, using multimodal approaches to extend survival in other solid tumors that are outside the thorax. Okay, so this is me, and I come from the NYU Grossman School of Medicine, where I'm the professor and vice chair of research in radiation oncology. I also direct our brain and spine tumor center and our cancer center and our MD PhD program in the medical school. So as I think most of you know, GBM is the most common primary malignant brain tumor in adults. The prognosis of patients who are diagnosed with GBM is very poor, and the prognostic factors that are most important are patient age, extent of surgical resection, to a lesser extent, tumor location, and then the underlying molecular subtype and the patient's performance status or functional status. In general, these patients do not have a long lifespan, and I'll talk about that in a moment, and treatment options have been very limited. So let's just briefly talk about how Tumor Treating Fields are delivered for patients with glioblastoma. It is a portable device. It's usually this sort of shoulder strap device with a battery pack and generator in it. The fields themselves are low intensity, 1 to 3 volts per centimeter. The frequency is 200 kilohertz, as I mentioned, which has been optimized for glioblastoma cells. The transducer arrays, which you can see in this image here, adhere to the scalp, which is maintained shaved, and contain within them the transducers, these discs, which are connected by wire to the battery pack. The placement of these arrays is individualized using special software to the patient based on the location of their operative cavity or their tumor. This is a case I'll present. It's a 71-year-old woman. She came in after having had a prior resection for a grade 2 meningioma of the right sphenoid wing. We're obviously not seeing that in this image. And somewhat unusual for a GBM, she did not have post-contrast enhancement, but she did have an abnormality on T2 flare, which showed hyperintensity in the left middle frontal gyrus. She underwent an awake craniotomy and had a subtotal resection, and pathology revealed glioblastoma. Based on the new definitions from the World Health Organization, this has to be IDH wild type to be called glioblastoma, and MGMT methylated in this case, and some other molecular features. EGFR was amplified and TERT promoter was mutated, pretty common in glioblastoma. She was dispositioned to receive standard chemoradiation with daily temozolomide, followed by adjuvant temozolomide with concurrent tumor treating fields. As I mentioned, tumor treating fields are mapped onto the scalp using software. This is the example of the array layout as determined using the software. The goal is to maximize field intensity of the tumor, and it uses the patient MRI as well as the shape of the head to determine where to place the arrays, and then a printout is generated which shows where they belong. The trial that established the use of TT fields as standard of care adjuvantly for newly diagnosed glioblastoma is this EF14 trial. And as you can see, patients in this trial were given standard chemoradiation and then randomized to adjuvant temozolomide or adjuvant temozolomide with tumor treating fields through second progression. They were encouraged to wear it at least 18 hours a day, and they stopped wearing it at 24 months if they had not progressed a second time at that point. Patients were stratified based on extent of resection and MGMT status. And as you can see from this Kaplan-Meier curve, this is the version from 2017 showing a improved survival, significantly improved survival. You can see at 2 years, 43% with those wearing tumor treating fields versus 31%. And you can see that this increase sustained throughout the duration of follow-up. So even at 5 years, where temozolomide alone had a survival percentage of only 5%, addition of tumor treating fields increased that to 13%, which is quite dramatic increase. And when looked to see the benefit, if it was durable, regardless of other prognostic factors, like the ones I mentioned a moment ago, you can see that the use of TT fields in combination with temozolomide was beneficial, whether or not the patient was MGMT methylated or unmethylated, whether the extent of resection was biopsy only or gross total. independent of age. So elderly patients benefited from tumor treating fields just like younger patients. Performance status did not matter, and patient gender did not matter. So as a result of this trial, the use of tumor treating fields had category 1 status within the NCCN guidelines, regardless of methylation status, both for patients younger than 70 and for patients over 70. This is in contrast to some of the other recommendations of the NCCN, which do not have category 1 evidence. Indeed, the only treatments that do have category 1 evidence in elderly patients are, of course, from the Canadian NCIC trial, which was the use of hypofractionation radiation with temozolomide, or the use of tumor treating fields and standard fractionation. Importantly, quality of life did not diminish with the use of tumor treating fields. So this is on the left, of course, the Karnofsky performance status. You see no change compared to temozolomide alone with the addition of tumor treating fields at 1 year, and you see no change in the patient-reported outcomes at 1 year. The survival benefit was observed when patients used tumor treating fields at least half the time, and the majority of patients used it at least half the time. 86% of patients in the trial wore the device more than half the time. The longer the patients wore the device, the greater the survival benefit. You can see those blue bars get longer and longer as you get to basically wearing it 100% of the time. All of these, whether it's 12 hours up to 24 hours, all these improved statistically over temozolomide alone. An interesting analysis done using the MRI data from the EF14 trial was done by Matt Ballo a couple of years ago and looked at basically 2 parameters. One is called the field intensity, shown on the left. That's measured in volts per centimeter. And these are electric field parameters that are common to electric fields, not even specific to tumor treating fields, but known about in electric fields. And the other parameter is called the power density, and that's in milliwatts per centimeter cubed. And it's interesting because this is a way of translating the use of tumor treating fields into a dose, similar to the absorbed dose, the gray, of course, which we all know from radiation oncology. This is the analogous metric, the power density. And you can see that using these thresholds, so greater than or equal to 1 volt per centimeter versus less than 1 volt per centimeter, there's a significant survival benefit with the larger field intensity. Similarly, if you look at the power density greater than or equal to 1.1 milliwatt per centimeter cubed, you see that there's again a survival benefit. And so what we start to see is that there is a dose relationship, a dose response relationship. And they followed in this study a rather interesting analysis. So they looked at the imaging at recurrence versus the imaging at initial diagnosis, and they mapped the recurrence to the original tumor. And what you can see is that if you look at the average dose density or power density, when the area went from tumor area to normal area, so not tumor, you can see that the dose density was much higher, statistically significantly higher, the 0.83, than when they looked at an area that progressed, where there was normal tissue. So that's this area right here, normal tissue that becomes tumor at recurrence. You can see that this number is much lower, suggesting again that if you can give higher dose to the tumor, you decrease the risk of recurrence at that location. So there are now many emerging strategies with the use of tumor treating fields in the brain. There's an ongoing single-arm phase 2 trial called To the Top, which is using adjuvant temozolomide, tumor treating fields, and pembrolizumab as a combination. There's some other strategies to try to improve that power density by using high-density transducer arrays, in this case in recurrent glioblastoma, another phase 2 trial. And then there's a trial which is using scalp preservation with combined tumor treating fields, radiation, and temozolomide, and looking basically at the scalp toxicity from that. And I'll talk a little bit more about that in a moment. And then just to switch gears just for a second to mention a couple of brain met trials. There's the very long ongoing phase 3 trial called the METIS trial in patients with brain metastases from non-small cell lung carcinoma, looking to see if tumor treating fields can reduce the occurrence of additional brain metastases. And then there's, interestingly, a trial now in small cell lung carcinoma, phase 2 trial, looking again to see if you can prevent the occurrence of brain metastases in small cell. So I'll just highlight this other trial, which is called the Trident trial, or the EF32 trial. And this is a trial in newly diagnosed glioblastoma. It's a very large trial. You can see that N is 950 patients. Patients are randomized to get now radiation and temozolomide, so standard of care plus tumor treating fields, followed by tumor treating fields plus temozolomide, or standard of care, which of course is radiation with temozolomide, followed by tumor treating fields and temozolomide. So the question here is just, does concurrent radiation and tumor treating fields improve survival? And this trial has been accruing for some time, and hopefully we'll have an answer soon on this trial. Okay, so 5 principles of delivering efficacious therapy for tumor treating fields. So I'll sort of summarize a lot of what we just talked about. Low frequency for large cancer cells, that inverse relationship. High frequency for small cancer cells. Intensity, greater than or equal to 1 volt per centimeter. And time, longer is better. We don't really have an absolute number of time. Longer is better. It's not 18 hours, it's not 12 hours. The more you can, the better. Power density, greater than 1.1, greater than or equal to 1.1 based on the Matt Ballow's work, associated with improved survival. Dose density, I didn't mention dose density. Dose density is power density times the number of hours, the compliance. And that has, again, you see this improvement in survival with both longer use and delivery of higher dose. So this combines sort of the patient's compliance and the physician's ability to prescribe that higher dose in the planning of the array distribution. All right. So we're going to get back to some questions now. Rethink your choice. Which of the following has been demonstrated with use of tumor treating fields in the treatment of patients with glioblastoma? Number 1, I don't know, I'm not sure. 2, software-generated treatment mapping that increases tumor treatment fields dose delivery at the tumor bed is associated with an overall survival benefit. Number 3, older patients greater than or equal to 65 derive less OS benefit from tumor treating fields than young patients. Only patients who use tumor treating fields greater than 18 hours a day realize an OS benefit. And 5, tumor treating fields frequency is directly proportional to cancer cell size, i.e. higher frequency affects larger cells. Okay, great. Okay, so let's see. So we have the blue is the pre-question, the green is the post. I guess my arrow doesn't work on this. Glad to see that people realize number 2, and I won't spend a lot of time on this. All patients of all ages benefited. Any increase in time benefits doesn't have to be 18 hours, and it's inversely proportional. Okay, so let's get back to this patient case that I mentioned before. So you can see that after this patient began treatment, some contact dermatitis was observed, and this is something that we do see with some frequency. In fact, is truly almost the only adverse event is the skin toxicity from the adhesive. So we're going to talk for just a couple of minutes about how we might address that and how we might manage that in our patients. Okay, so the symptomology of this, it's often itchy, it's skin rash, it's red, it looks like a burn. Sometimes it has bumps, sometimes it weeps with blisters. It's typically localized to sort of match the adhesive, but for some people who are very sensitive to the adhesive, it's actually a more diffuse and spreads out. Okay, let's talk about management. Topical corticosteroid lotions, solutions are the first choice in management, and they often are all that they'll need. Patients are educated to change arrays at least every 3 to 4 days. When they change the array, they can shift it a couple of centimeters to avoid hitting the same spot over and over again, and then move it back to the original position, so they're sort of giving a little bit of a rest. If blistering develops, cold, moist compresses are recommended, 20 minutes 3 times a day, and if it persists, you can use systemic corticosteroids or even give treatment breaks. It's always recommended to have a dermatologist. Many centers, my center has an oncologic dermatologist who we partner with to help with the management of these situations when they become severe. If it's simple contact dermatitis, we just prescribe the steroid cream or lotion. Clinical trials have demonstrated a varying rate of skin adverse events. And if we look at, say, the EF11 trial, patients had with skin adverse events, 16% of them, but no grade 3 or higher. If you look at the EF14, again, it was a lot of patients in the newly diagnosed trial had skin dermatitis, but only 2% had a grade 3 issue. And if you go down the list, you can see that is true in the brain. And when we start to get to other parts of the body, the numbers go up a little bit. And you can see in the PANOVA trial, which is a trial of pancreas, the rates of grade 3 were a little bit higher. And this has to do partly with the use of the chemotherapy that's used. So we're going to have a panel discussion here among the panelists. And we're going to talk about how we each manage dermatologic adverse events. I think I've talked about kind of some of the general guidelines, but I wanted to ask each of you, do you have specific approaches that you use, maybe based on some of these situations that you see here in this table?
Sure.
Go ahead.
I'll go first. I'm Zach Horne from the Allegheny Health Network in Pittsburgh. As with many on-treatment issues that we deal with, a bit of prevention can actually be the best treatment possible. So when I first meet with patients and we're discussing tumor treating fields, I go over a fairly regimented array replacement protocol. The arrays have to be replaced at least every 3 days, and I go over a process through which patients can soften the adhesive on the arrays, clean their skin with a neutral makeup remover, apply either a Benadryl spray or a steroid spray, allow that to sit on the skin for about 10-15 minutes, and then re-clean their skin with a neutral makeup remover before applying their new arrays. That way they keep their skin clean. If they are having some low-grade toxicities like pruritus, they're managing them more proactively, and they don't progress to something more serious that results in needing an escalation of care or a treatment break, and that has seemed to work out pretty well.
Excellent.
So, at our facility in Miami, we encounter these skin-related ADEs commonly as well. I think, as you see in the very first part of that diagram, a human environment, such as what we have in Miami, adds to this issue. And as Dr. Horne mentioned, we also do an evaluation with the patient and their entire family and educate them about the potential AEs that this can cause. I think the first thing to establish with the patient is what you had mentioned, Dr. Sulman, that it's really the only AE associated with the device or treatment. So first of all, just providing that information to the patient gives them that comfort. They're going to have other chemotherapies, which are going to cause other toxicities. This is essentially the toxicity that they have to manage with this. So first is education. Second is making sure that they understand that there may be topical corticosteroids that would be involved. Actually, sometimes, especially for extracranial sites, we pre-prescribe those to the patient so that they have them available at the pharmacy if they do develop any AE within the first couple of days of utilization. We also have our nurses call the patient within 1 week of the treatment start if we haven't heard from them to talk about potential management of skin-related AEs. And then finally, we use a lot of barriers or wipes to also help with that.
Excellent. And I think you brought up a good point, is that if you have your team in your clinic well-trained, well-educated, who can sort of, especially your nursing staff can identify these issues at the very, very earliest time point and intervene very early, it makes a big difference for these patients. This practice aid is available for download, again, at PeerView. And I did want to mention, because it came up as a question, try to choose topical treatments that minimize electrical impedance. That is, water-based is preferred, whereas petroleum-based can cause electrical impedance, and that can cause difficulties with the function of the arrays. So water-based, not petroleum-based. Oh, thank you. Polling question number 2. Which of the following is true about effective management of dermatologic events that may be caused by tumor treating fields arrays placed on the shaved scalp? Number 1, I don't know, I'm not sure. Number 2, petroleum-based ointments should be applied since they will not affect TT Field's electrical impedance. Number 3, treatment, topical steroids or topical antibiotics should be based on type and severity of the AE and applied at the time of array changes and shifts. Number 4, water-based lotions, soaps, foams, and solutions should be avoided due to their increased impact on electrical impedance. And number 5, prophylactic measures, optimal shaving, array positioning to decrease risk and severity of dermatologic AEs have proven ineffective. All right, great, very good. So hopefully the emphasis was clear and everyone did very well. And it is true that it's the petroleum product should be avoided, shifting does a good job, and water-based should be used, and it's the things that we mentioned, the corticosteroids, antibiotics, can be varied based on the severity, so very good. Okay, this is the patient case. Just to point out, this patient, 71-year-old patient already, being 71 is already a poor prognostic factor for this patient. The patient continued with, which we sometimes see, decreasing compliance in terms of the number of hours worn of the tumor treating fields. However, the patient was very committed, stuck with wearing it as long as possible, progressed a couple of years after diagnosis, so a really prolonged time to progression of almost 2 years. And then at progression, continued to wear the devices. We say we recommend, based on the EF14 trial, really indefinitely, but at least a second progression. Compliant, became functionally somewhat impaired, and compliance dropped off for a while. Patient continued to do reasonably well. In other words, is still alive 34 months post-diagnosis. I can tell you now the patient is, this is a somewhat outdated slide, is still with us, so doing very well. Okay, so we're going to switch gears a little bit and hand over to Dr. Kotecha on multimodal treatment of thoracic cancers, we'll say, all of them. Thank you.
Thank you. So now we'll transition to malignant pleural mesothelioma and other thoracic malignancies, especially non-small cell lung cancer. This is an area where we are gaining ground with the use of TT Fields utilization and with clinical trials. First thing I want to point out as we transition to the chest is that the transducer array setup is a little bit different. Those arrays actually come in 2 sizes now. The small, which you can see pictured here, is 13 ceramic discs, and the larger one then will have 20 ceramic discs. Basically, we're trying to cover as much of the tumor burden as possible within our array layout. That size choice is then determined by the individual anatomy of the patient and their disease extent. We know from the finite element mesh modeling simulation studies that have been performed that the electric field distribution for TT fields arrays when they're placed on the chest does cover the lungs, and so that allows us to treat patients with malignant pleural mesothelioma, even with very extensive disease. The intensity of those TT fields when we apply them to the chest is above that 1 volt per centimeter threshold that Dr. Sulman had mentioned in the last section, and so that's above that threshold needed for a response to treatment. That field distribution is higher in the mesothelium than in the lung parenchyma as well, and you can see how that differs with the different conductivity of tissues on that picture on the right. The personalization of the TT fields layout for an individual patient does facilitate the delivery of higher TT fields intensities to the area that we're actually treating, which is important as we think about the potential efficacy of this treatment to different sites. Now, the best data that we have to date that supports the use of TT fields for patients with malignant pleural mesothelioma came from the single-arm open-label phase 2 study, which was the STELLAR trial. In this study, patients who were unresectable malignant pleural mesothelioma were enrolled if they had pathologic evidence of unresectable disease, had at least one measurable lesion, and had a good performance status. Key exclusion criteria were that patients could not be candidates for curative treatment, they couldn't have significant medical comorbidities, and specifically, they couldn't have any implanted electronic medical devices. These patients received TT fields at that different frequency than in the GBM space. Again, this is a cell-specific frequency of 150 kilohertz for at least 18 hours a day with platinum-based chemotherapy and pemetrexed for a total of 6 cycles. And then they continued their TT fields as their maintenance treatment, and they had follow-up every 6 weeks. The primary endpoint for this study was actually overall survival compared to a historical control with chemotherapy alone. And there were a number of secondary endpoints that we'll also touch on as well. So here's the headliner. The primary overall survival for this study was a median survival of 18.2 months. So this was significantly longer than what the historical threshold was, with a hazard ratio of 0.66 and a statistically significant p-value. The 1-year overall survival was also 62%. The median overall survival specifically for epithelioid patients was extended at 21.2 months. And then we also saw an extension in the median PFS at 7.6 months, and this was higher again in patients who had epithelial histology compared at like 8.5 months versus 6.3 months for those who had non-epithelial histology. We'll talk about the last 2 parameters, radiologic response rate, in the next couple of slides. So first, to go back to those results of that median overall survival, again here the result was 18.2 months with about 2/3 of the patients having epithelial histology. We know this is a key prognostic feature for patients with mesothelioma, and if you look at the other trials, it has to be accounted for when we look at survival estimates. So for example, if you look at the original cisplatin pemetrexed data, the same proportion is there, but then if you look at the MAPS trial, that percentage goes up to 80%. And for example, in the LUM-MESO trial, essentially all of the patients had epithelial histology, and even with that, the survival was only 16.1 months with that regimen alone. So if you think about that 16.1 months, instead of comparing it to the 18.2, that really should be compared to the 21.2 for patients with epithelial-only histology in the STELLAR study. And that's where we see that benefit or that survival difference. Now, about 72 patients actually had at least one CAT scan for follow-up, and so we had radiologic response evaluation. There was a partial response in 40% of the patients, and then the clinical benefit rate, which is essentially what we think about with systemic therapies of partial response and stable disease, was actually 97%. The median time between start of treatment and partial response was 1.8 months, so patients responded quickly. And then all of the patients who had a partial response continued to have reduction in the total sum of their lesion diameter tumors, with a median response duration of 5.7 months. So although these response rates are similar to what we think about with systemic therapy alone, that durability or that response duration is longer with TT fields therapy. So this led to the FDA approval as a humanitarian use device under the humanitarian device exemption pathway, given that it's a rare disease. There are some caveats to how we interpret this data. So for example, more than 50% of these patients had a performance status in ECOG of 0. So that is also another prognostic feature that we should take into account when we interpret the data. There are a subset of patients who may respond better to TT fields, but other subsets that may not respond as well. We don't have a biomarker for response to treatment like we have with PD-L1 expression with immune checkpoint inhibitor therapy. The PFS of 7.6 months was very modest, and a response rate was 40%. This is similar to systemic therapy alone trials, and then you have an overall survival of 18 months. So there's something there with regards to the salvage therapies that you potentially would like to know about. This was a single-arm phase 2 trial, which is different than the glioblastoma studies that Dr. Sulman presented, which were phase 3 randomized trials. We don't know the optimal treatment duration and usage or rates. And then obviously we have to consider costs with any of these maintenance therapies. That being said, I think it does integrate into our options for malignant pleural mesothelioma. You can see at the top of this slide, essentially patients now fall into 3 buckets. Those who have limited disease to one site, that have limited or no nodal metastasis and excellent performance status, and typically epithelioid histology, and can undergo a macroscopic resection, get surgery, an extrapleural pneumonectomy or pleurectomy decortication, adjuvant radiation therapy, typically on ongoing trials as well, and with neoadjuvant or adjuvant chemotherapy. For the patients who are not a candidate for surgery, options can include chemotherapy alone, chemotherapy and a biologic agent, immune checkpoint inhibitor therapy, which we'll discuss in the bottom of this slide, as well as chemotherapy plus TT Fields treatment. Now, specifically in the last 2 years, we had the approval for immune checkpoint inhibitor therapy for patients with malignant pleural mesothelioma. If you specifically look at the highlighted box in red, that was for non-epithelioid patients where you see that median survival difference of 18.1 months versus 8.8 months. So this is a dramatic and statistically significant difference. But then if you go back and look at the other subset, for example, epithelioid patients, the difference is only 16.5 versus 18.7, not statistically different. And then if you look at the patients who are PD-L1 less than 1%, even with Nivo-Ipi, we see differences than what we saw in the lung space where there's no statistically significant benefit. It was 17.3 versus 16.5 with chemotherapy alone. So for those subsets of patients, we actually are treating them upfront with, for example, TT Fields and chemotherapy, and then transitioning to immunotherapy as a second-line option. This is a case treated at our center, 84-year-old with unresectable malignant pleural mesothelioma, epithelioid histology. He had disease predominant in the left hemithorax, a little bit hard to see with these very small PET scans. But he started off at about a 57% usage rate with grade 2 skin blisters. And again, with 2 cycles of chemotherapy, he then had fatigue, cytopenias, a decline in his performance status, not unsuspected given his age and given the chemotherapy regimen, and this resulted in a decline to about a 32% compliance. He did want to continue using the device, and therefore after he completed his therapy, after we started using corticosteroid creams for the skin, he was able to improve his compliance and continue wearing the device. These are the pre-treatment versus post-treatment images that show a partial response to treatment with a reduction in the thickness, essentially, of his pleural disease. So going back to this now, how would you now treat an 84-year-old man, newly diagnosed, medically inoperable, unresectable, malignant pleural mesothelioma, assuming that he has epithelioid histology, a good performance status? Number 1 is I don't know or I'm not sure. 2 is neoadjuvant chemotherapy and pleurectomy decortication. 3 is pemetrexed cisplatin. 4 would be platinum-based chemo and radiation. And 5 would be pemetrexed carboplatin and concurrent TT Fields. Excellent, so 93%. I think that will be the new baseline threshold. So at our cancer center, we started this HD process. So giving you a timeline, the FDA approval, as you heard from Dr. Sulman, came in May of 2019. I actually always was a provider for GBM in that space, and we had an ongoing trial in the lung space, and so we did the clinical training right away. I started the protocol at our cancer center, which we received our IRB regulatory approval through the HD process in September. I treated the first patient in October, and then we did essentially 2 years later, we did an outcomes analysis for our first patients. So this is the first 5 patients. Interesting enough, all were treated essentially for the first year that we were running this protocol, so all of them are still alive now 2 years out. As you can see, 4 out of the 5 actually have recurrent disease and are still alive. Most of these patients have epithelioid histology. Although it's difficult to see on the bottom of this, I do want to point out this was a patient that we had treated for extensive disease in the right hemithorax. You can see in A and B, the tumor treating fields layout, where we're trying to use those larger discs to help encompass all of her disease. In C and D, you can see skin-related AEs associated with the device and treatment. We did extensive use of wipes, replacement, frequent exchange rate changes. Essentially in E and F, you can see that her skin has improved significantly, and she continue wearing the device at a high compliance rate. In G and H are actually her pre-treatment and post-treatment PET scan, and that's essentially almost a complete response to treatment, very little minimal residual disease, and we almost stopped TT Fields treatment to send the patient actually for surgery. So she went from being unresectable to potentially resectable. So moving on from mesothelioma, there are also multimodal therapy considerations with the integration of TT Fields for patients with lung cancer. Typically, we see extensive disease in the chest. This is an example of a patient of mine who's had progression of lung-predominant disease after first-line chemoimmunotherapy. When we go back to the NCCN guidelines, these were the ones that were released in May of this year for patients who have a good performance status but have metastatic disease. First-line therapy is typically systemic therapy, 2 to 4 cycles with tumor response evaluation that's typically performed after 2 or 3 cycles, and then a patient continues on maintenance therapy. At some point when they progress, if they have a good performance status and have not received prior immune checkpoint inhibitor therapy, they can receive it at that point, but that's very rare. At this point, patients receive single-agent immune checkpoint inhibitor therapy or triple therapy. And so essentially patients now as second-line option receive docetaxel, pemetrexed, gemcitabine, or a combination agent. And essentially it's dealer's choice at this point. We do have data, though, about the safety and survival results of the use of TT Fields with second-line chemotherapy. This was a phase 1, phase 2 trial in patients with recurrent metastatic non-small cell lung cancer. Again, this is a single-arm study. And if you look at the median PFS for patients treated with TT Fields and pemetrexed, it was 28 weeks compared to pemetrexed alone with a historical control of 12 weeks. And the median OS was 13.8 months compared to a historical control of 8.2 months. Important to note, the only device-related AE that was seen was mild to moderate dermatitis, reported in 14 patients and improved in all of those. The phase 3 LUNAR study is really the large trial to answer this question of the benefit of TT Fields in patients with metastatic disease, but do have significant pulmonary component of their disease. This is a large international randomized controlled trial in patients who have progression on or after platinum-based therapy, and they are randomized to TT Fields plus the second-line systemic therapy option, dealer's choice, essentially immune checkpoint inhibitor therapy or docetaxel. Patients were followed in this study with a primary endpoint of overall survival. So this will give us evidence, like we have in the GBM space, using a phase 3 randomized trial. The number of secondary endpoints that are key to note, including progression-free survival and overall radiologic response rate. This study was initially going to accrue 534 patients. In April of 2021, the DSMC reviewed the data for the first patients that were included in this study, and they recommended that we close the trial at 276 patients early, as long as they had 12 months of follow-up, since we would have enough we would have enough power to actually answer both the primary survival question as well as the secondary endpoints. So we're excited to see the results for this. The top-line data are expected to be announced in the first quarter of next year. This is a patient of mine who we enrolled onto this study, a 71-year-old with a history of stage 4 non-small cell lung cancer, and she came to radiotherapy evaluation due to rib metastasis. As you can see here, essentially profiling showed that they are negative for all pertinent mutations for lung cancer, and they had a PD-L1 of only 3%. He started with 3 cycles of triple therapy and then has disease progression. You can see he has extensive pulmonary component with a large right upper lung mass, paratracheal, and hilar lymphadenopathy. After discussion of second-line treatment options, he enrolled into the LUNAR study. He received docetaxel, given that he had progressed on triple therapy and he had a PD-L1 of only 3%, and then he was randomized to the experimental TT Fields arm. Given the location of his disease, this was actually his tumor treating fields layout on the trial. So to reassess your knowledge, can you identify which patients have been randomized to receive the combination of TT Fields and standard of care therapy in the phase 3 LUNAR trial? First is that I don't know or I'm not sure. Second, patients with newly diagnosed stage 4 non-small cell lung cancer. 3 is patients with stage 4 non-small cell lung cancer who have progressed on platinum therapy. 4 is patients with stage 4 EGFR mutated non-small cell lung cancer progressing on prior therapy. And 5 is patients with stage 4 non-small cell lung cancer progress after multiple lines of prior therapy, including chemotherapy and immune checkpoint inhibitors. Okay, so we have, I'm glad that we reduced the number of people, or the proportion that did not know. This is a trial for patients who, in option 3, who were stage 4 non-small cell lung cancer, who progressed on platinum-based therapy. So moving to the first-line setting, this is the phase 2 Keynote B36 trial. This recently activated to accrual at our center. This is a trial in its current iteration for patients with unresectable intrathoracic stage 3 or stage 4 non-small cell lung cancer who are PD-L1 positive with a minimum % of 1. The patients will receive TT Fields and pembrolizumab, and then the primary endpoint for this study is overall response rate. There are also a number of secondary endpoints as well. This trial is open to accrual with a total N of 66, but is actually currently in redesign, and there's an amendment that's already been approved, which will then redesign this study to make it a larger trial. Finally, I'd like to leave you with the consideration that as we are having increasing data for TT Fields in the thoracic space, we have a lot of therapies that are quote-unquote maintenance treatments in lung cancer. And so the question is, could we integrate TT Fields with those treatments? 2 examples I'll give you here is for patients with extensive stage small cell lung cancer. Typically, they receive triple therapy now, and then if they respond to treatment, receive consolidated radiation therapy to the chest, and then maintenance immunotherapy. For example, we did a study at our institution recently where we also gave a PARP inhibitor in addition to this entire regimen, but still intrathoracic failure continues to be a common occurrence. So the question is, when they're on their maintenance immunotherapy afterwards, could TT Fields also help to reduce this intrathoracic disease progression, and could that translate to an improved survival of our patients? Similarly, in patients with stage 3 non-small cell lung cancer who are not receiving trimodality therapy, this current standard of care is to offer them concurrent chemoradiation therapy followed by a year of adjuvant durvalumab. And the question is, again, during this maintenance phase, could TT Fields be added to help improve our disease control rates? These are curative patients, to improve the progression-free survival and then improve overall survival. So clinical trials are being developed and designed to help integrate TT Fields as future maintenance treatments, but I think there are many opportunities for its integration in the future. Now, as you heard from Dr. Sulman, that the skin AEs do differ as we think about different sites, both cranial indications and extracranial sites. And there are differences in the skin characteristics by those body areas that may explain some of these discrepancies or differences across clinical trials. So this is a table that we had put together between dermatologists and radiation oncologists. And there are differences with regards to the mean skin thickness, the hair follicle density, obviously the differences in radiotherapy that patients may have, elasticity of the skin, eccrine sweat glands, sebaceous glands, as well as if those areas are covered with clothing. These are just pictures of TT Fields associated skin AEs that we see in the chest. As you can see, these categories are the same as what we see in the scalp, but their presentation or their appearance or even the severity or their proportion of recurrence are different in the chest compared to the cranial indications. Of keynote, these are a number of strategies that we have put together for management as well as prevention of skin AEs, specifically for thoracic indications, as this is being increasingly used for patients either off study, for example, for mesothelioma, or on one of the clinical trials for management for lung cancers. These are clinical guidelines that are due to be published probably this week, I think. So this is just an early look at those. So going back to the panel discussion.
Okay, so in this short panel discussion, we're going to focus on how we would necessarily in our practices implement these new modalities or how they've been implemented, and just sort of mention the device support specialists, the DSSs, and maybe I'll ask you guys how the DSSs have been integrated into your practice in a way. So.
Sure. So I think from our perspective, the DSSs have been integral to the management of these patients. I mean, different from, for example, when you're giving IV systemic therapy. Patients are in, they're seeing nurses at the infusion suites, and they have constant contact with support. So the DSSs are really key because they're able to assess those patients in their home, in their environment. They're able to answer their questions, whether it's about array placement, the use of the equipment, or other things with skin care, or directly contact us as the clinical team to be able to address any skin AEs that the patient may be experiencing. So I think they're really key and vital to a patient actually maintaining usage or compliance with the device.
And then maybe a different question for you is how do you manage the follow-up and the routine care in your clinic?
Sure. To build on that, the DSSs can be really integral into tipping us off that there is something starting to happen with a patient. Maybe it's not a severe AE, but something that could potentially become one in the 6 weeks until you see the patient next. One of the minor silver linings of the pandemic is that telemedicine has become very prominent, easy to use, and can be set up, within a few hours to see a patient. So the DSS may have contact with a patient and say, oh, Mr. Jones is having scalp irritation, and he said he's using his arrays less. You can get a virtual visit set up with that patient within the day or two, so that you can actually lay eyes on that person's scalp, especially if they come from a distance and they can't get in easily. So that's been another big benefit.
Excellent point. And I would just say for glioblastoma patients, it's common practice among radiation oncologists after maybe the first follow-up to discharge the patient to the neuro-oncologist to continue management with temozolomide. But now with the use of tumor treating fields, in my practice, I continue to follow these patients indefinitely along with the neuro-oncologist, which I think is both important for being the one that prescribes the tumor treating fields, but it's also, I think, beneficial to the patient to have a radiation oncologist providing long-term follow-up and not just the neuro-oncologist. Okay, great.
All right.
Okay, Dr. Horne, take it away.
So with that in mind, we're going to talk about the future of TT fields as it's being applied in other sites. We've been working our way from the skull to the thorax, and now we'll talk about some other indications that are in progress. So there are a number of other solid malignancies outside of glioblastoma and lung cancers and mesothelioma that still lag behind in terms of good treatment options that produce durable responses with minimal morbidity. Typically, combinations of surgery and chemotherapy, targeted agents, all come with significant adverse events that impact quality of life. And so there is this rationale that we can potentially combine tumor treating fields with some of those standards of care in an attempt to prolong progression-free intervals, improve on response rates, and only minimally add to the morbidity of treatment. So the PANOVA trial evaluates the use of TT fields in pancreatic cancer. Preclinical data indicated that the combined treatment with TT fields and gemcitabine induced the highest treatment responses in terms of tumor volume reduction of any of the tested regimens. And as we noted, there's that inverse response to tumor cell size. Pancreatic cells respond to 150 kilohertz, and you're able to place these arrays on the abdomen just as they were placed on the thorax for lung cancer. And so we have data from the PANOVA study, which is an evaluation of tumor treating fields with gemcitabine and Abraxane in locally advanced pancreatic cancer. The study enrolled 40 patients, and as you can see in the curves below, the median progression-free survival was almost 8.5 months with a median overall survival of nearly 15 months. And you can see that there are, of course, different outcomes in the locally advanced population versus the metastatic population, which you would expect. But especially in that locally advanced population, the progression-free and overall survival curves are quite encouraging. In comparison with standard Abraxane and gemcitabine-based chemotherapy regimens, you can see that the median progression-free survival and overall survival numbers are significantly higher compared to their historical controls. The one-year survival rate in particular is doubled compared to chemotherapy alone, as is the partial response rate, and the clinical benefit rate is nearly 90% compared to 50% with chemotherapy alone. And so this has led to the randomized phase 3 PANOVA-3 trial looking at standard of care chemotherapy, Abraxane and gemcitabine, versus that combination with tumor treating fields. And again, the primary endpoint in this study is overall survival, as it is in the majority of the studies we've been discussing, with a number of secondary endpoints. It's currently accruing. They're looking for about 550 patients for adequate powering, and this is ongoing. There are other modalities for treating locally advanced pancreatic cancer that are being evaluated at present. This is a list of just a small sample of different studies that are ongoing that look at either checkpoint inhibitors, intraarterial chemotherapy, the nanoknife system for ablation, different chemotherapy regimens. And so there are a broad variety of clinical trials right now looking to move the needle in pancreatic cancer because it is such a difficult disease to treat, just like mesothelioma and glioblastoma. Other intra-abdominal malignancies that are typically difficult to treat include hepatocellular carcinoma and gastric cancer. The phase 2 HEPANOVA trial evaluated the role of tumor treating fields in advanced hepatocellular carcinomas. Again, that targeted frequency is 150 kilohertz, and it was used with concurrent first-line sorafenib for unresectable or advanced hepatocellular carcinomas. It was used with daily sorafenib until progression, and they had imaging at regular intervals to help evaluate the response rates. For this, because it was a single-arm phase 2 study, the primary endpoint was radiologic response rates. Overall survival was a secondary endpoint. And you can see how the arrays are positioned in the images below, in between where thoracic arrays would be expected and perhaps pelvic arrays would be expected to cover the liver. In the phase 2 HEPANOVA trial, they enrolled 27 patients. As you can see, the median duration of therapy was 9 weeks. The disease control rate was 76%. In those who were on treatment for greater than 12 weeks, however, the disease control rate was 91%. In comparison with historical controls, that's almost double. And again, the overall response rate for the entire study was about 10%, and if they remained on treatment for greater than 3 months, the overall response rate was 18%. That is a big jump in comparison to historical control. There is presently a phase 3 randomized study being conducted with the new standard of care in frontline unresectable hepatocellular carcinoma, which would be atezolizumab and bevacizumab, and evaluating the inclusion of tumor treating fields into that regimen. The phase 2 EF31 trial evaluated the role of tumor treating fields in gastric cancer. The efficacy with FOLFOX had been demonstrated, showing a higher response rate with the combination of the regimen versus any regimen by itself, and this led to the pilot study that evaluated response rates. And so this study enrolled patients with confirmed diagnosis of gastric cancer that was felt to be either unresectable, node positive, or metastatic, and it evaluated the use of tumor treating fields with the Zelox chemotherapy regimen with the possibility of adding trastuzumab or Herceptin for patients who are HER2 positive. They enrolled 28 patients, and it was designed again to assess overall response rates for comparison to historical controls. So another polling question. Let's rethink your choices. Which first-line treatment strategy is being tested in the EF31 trial of patients with GE junction or gastric adenocarcinomas? Number 1, I'm not sure which treatment strategy is being tested in EF31. Number 2, tumor treating fields plus standard of care chemotherapy with trastuzumab for HER2 positive patients. Tumor treating fields alone, number 3. Number 4, tumor treating fields plus immune checkpoint inhibition, or number 5, tumor treating fields plus surgical resection. Great, 90% picked the correct choice. So we got close to that bar of 93%. Moving down through the body, tumor treating fields for ovarian cancers. Phase 2 INNOVATE trial looked at the patient population with platinum-resistant ovarian cancers, traditionally a very difficult population to treat. They've typically seen a number of lines of chemotherapy. Often their bone marrow won't tolerate much in terms of additional systemic therapy. Their response rates to available regimens tend to be pretty poor. And so this was a study evaluating tumor treating fields with weekly paclitaxel, which tends to be one of the last options that women with ovarian cancer see. As you can see, the median prior lines of therapy were 4. And so in this study, the median progression-free survival was just about 9 months. In comparison with weekly Taxol alone, it's usually only about 4 months. The median survival was not yet reached when this data was analyzed, and the median survival with paclitaxel alone in a weekly fashion tends to be 13 months. At 1 year, 61% of women who had weekly Taxol and tumor treating fields were alive, and unfortunately we don't have comparative data with weekly Taxol. The disease control rate was 71%, and only 1 patient discontinued due to dermatitis, which, as we noted, can be different depending on the region of the body where the arrays are placed. This has led to the phase 3 INNOVATE study, again in the platinum refractory ovarian cancer population. So it is taking the historical standard of weekly Taxol and comparing it with weekly Taxol with concurrent tumor treating fields. As with all of the randomized studies, the primary endpoint is overall survival, and we are expecting 18-month follow-up results from this in 2023 as this study has closed to accrual. And again, this is a space where there are innumerable clinical studies underway because the platinum-resistant refractory ovarian space is a very difficult site to treat. These are some other novel combinations of therapies across the hepatocellular space, GE junction, and other biomarker-driven type studies. And it's really meant to indicate how difficult these diseases are to treat, prompting the number of clinical investigations. Another follow-up polling question. How likely are you now to consider referring eligible patients with GI, thoracic, or gynecologic cancers to clinical trials testing novel multimodal treatment options such as tumor treating fields? Number 1, I typically do not refer patients to clinical trials. Number 2, unlikely. Number 3, somewhat likely. Number 4, likely. Number 5, I am very likely. And number 6, not applicable. Great. It looks like most of the audience is at least likely, if not very likely, to refer patients to a clinical trial that might include tumor treating fields. So future directions. Tumor treating fields and radiation therapy have complementary but non-overlapping mechanisms of action. DNA damage repair is delayed after radiation in the setting of tumor treating fields. Tumor treating fields also interfere with DNA double-strand breaks and the homologous recombination pathway. There's in vitro data that shows that tumor treating fields increase the expression of gamma H2AX, which is a marker of DNA repair. And there is plenty of in vitro data that when you combine radiation and tumor treating fields, you increase cell kill. For instance, the Trident study, where tumor treating fields are being applied concurrent with radiation for glioblastoma. It's also possible that tumor treating fields increase immunostimulatory signals, prompting combinations of something like tumor treating fields and checkpoint inhibitors, where the combination of the two may be synergistic and allow greater access to the immunocomplement to prompt higher response rates, and these are the subject of multiple ongoing clinical trials. Also, PARP inhibitors. Tumor treating fields have been suggested to induce a state of BRCA-ness. And what that is an inhibition of double-strand DNA repair gene expression. That could lead to increased susceptibility to radiation therapy, and it could also create a role for PARP inhibitors, which, for instance, in the ovarian space, play a very significant role in women who have BRCA mutations or are homologous recombination deficient. They've been shown to benefit from the use of PARP inhibitors. This may create an opportunity to reduce PARP escape, whereby women stop responding to PARP inhibitors, and is, again, the subject of ongoing preclinical investigation. So we need to prepare for the future. The importance of multidisciplinary and multimodal care for patients with cancer, including novel treatment techniques like tumor treating fields, is essential to providing the most current and optimal care for our patients. There are a number of prospective trials that are underway. Some will get data readouts from in the next few months to the next year, and other randomized studies are running full force, and over the next couple of years we'll have that data. So there is hope that even with difficult to treat tumor sites, we can make strides and do better for our patients. And now it's time for some question and answers from the audience.
Okay.
It looks like we've got a number of cards.
Right, and it's not too late to submit them. Again, we have a lot of questions here from the online folks as well. There's a couple hundred people connected online. We want to thank them for joining, and we'll try to get to these questions. Rupesh, and then I'm going to hand you these. Sorry, we're trying to divide. Those are yours there. No, the other way. So I kind of grouped some of the questions just in the interest of time, and we'll kind of take turns here. So I have a question about combining tumor treating fields with bevacizumab for glioblastoma. At this point, there's no definitive data on that. Of course, the use of bevacizumab for survival benefit in glioblastoma has not been shown, based on two newly diagnosed glioblastoma trials, which did not show a survival benefit. So we don't have great data on that. There's a question about long-term side effects to normal brain tissue with the use of tumor treating fields, whether there be cognitive decline. And we don't know of any. I mean, based on the patient-reported outcomes and the physician-reported outcomes, there isn't any evidence, but formal neurocognitive testing data we're somewhat lacking. Let me give the rest of that to you.
Okay.
And I'm gonna just jump through mine and then hand it over, just again to get as many questions answered as possible. Someone has asked whether the field intensity or power density can be escalated, and that's actually an active area of research. There's some treatment planning software being developed to do just that. And so that is, up until now, the treatment planning has been essentially, you might say, geometric dosimetry, kind of just using the location and trying to localize the arrays to hit the location the best as possible. But some actual treatment planning based on imaging data, similar to what we do with ionizing radiation, is well underway. And is there a relationship between skin toxicity and intensity and power? Not that I'm aware of, but I'll allow my colleagues to comment on that if they know.
There is, if the intensity goes above, I believe, 4 volts per centimeter, then the incidence of dermatitis does go up, which is why that target range is 1 to 3 volts per centimeter. That can keep things within an acceptable range.
Excellent, thank you. And I'll answer one last one and then hand it over to you. What is the mechanism or the mechanistic rationale for combining tumor treating fields with radiotherapy? So there was some preclinical data in glioblastoma showing a synergistic effect of the two, and this is what led to that. And actually, you just touched on this. The effect of tumor treating fields on cells is to cause some of the same types of damage we see with radiation. So it makes sense that combining the two would have a benefit. Okay.
All right. Any updates on ovarian and liver cancer data? Unfortunately, both of those trials need some more time to mature. What advice do you have for radiation oncologists considering integrating TT fields into practice? That's a great one, and that may be the most pragmatic one that could be asked. Reach out to Novacure. That's the first step. They will bring in their team to give more on-the-ground education, get you certified for prescribing, and give you really all of the tools that you need to start prescribing tumor treating fields and all of the resources that you need to help manage tumor treating fields, because those are both inseparable but necessary. As I think we've all mentioned in some form or fashion, we don't just prescribe tumor treating fields and then send the patients off to the wind. They do need ongoing management and evaluation to ensure that their compliance is good and that they aren't having any high-grade morbidity. And then certainly reach out to any of us as a resource. We're all always welcome and happy to help. And last, is this technology applicable to difficult GI malignancies, and would it be curative or palliative? That's sort of a two-pronged question. Certainly the hepatobiliary space is one that's being investigated, as is GE junction and gastric cancer. Presently, it is not being evaluated as a necessarily curative endeavor, but in many senses it can prolong survival, or at least that is the goal of these studies. In the future, there may be sort of other indications that are evaluated and explored in a more curative fashion, where we think of neoadjuvant treatment, but at present none of those exist. They're typically for unresectable, incurable diagnoses.
Sure. So the first question that I have is, the barrier to TT fields is often a major inconvenience of the large battery pack that they must carry. This is definitely something that we see with extra cranial indications, given that the original approval of the device was the original version of the device. Actually, we've seen with the most recent changes that we can use the smaller and lighter device now for our patients. So for example, our meso protocol, we revised to include the second generation device, which is a lot lighter, and so patients were able to go to the new device. It is obviously a concern that in the future, hopefully we'll make it lighter and lighter. I actually just brought this up most recently in a conference, and I asked, how come we went from a corded phone to an iPhone that we all carry now? But the amount of energy that machine actually needs, or that we need to put through the transducer arrays, needs a lot of technology development before we can get there. Another question I had is, what are the best strategies to maximize compliance with TT fields therapy? This is something that is very variable, especially as we think about outside the GBM space with other malignancies. In fact, actually, this year at ESTRO, we collected data from patients treated with mesothelioma throughout the United States, and we saw quite a significant variability in patient usage, especially after the first 3 months, and that's typically where you see the highest usage for patients, and then it drops pretty significantly, especially with patients living longer for their systemic disease. Our goals are really to have patients use it as much as they can, and so we have a number of hypotheses out there. Could we change, instead of patients just wearing it, for example, 18 hours just straight? Is there a fractionation component that can be done? So for example, can they wear it 30 hours straight and then be 2 days off and then on for a period of time? So we've put together proposals for kind of different ways of fractionating out that treatment so that patient can overall maintain that compliance rate or usage rate of 18 hours, but can be broken out a little bit differently. And the last question, right, sorry, I have two more. AE management, I think we've talked a lot about it, but also reimbursement and treatment. So reimbursement of treatment for extracranial sites is done essentially per insurance basis. I've actually gone to do decisions for patients as well. I actually went to court even for a patient to make sure that it was approved, which I think we haven't had major issues with, fortunately enough, given that we have data in these spaces to use this treatment. And then finally, why do you feel that adoption has been so slow? It is variable across different sites. As Dr. Sulman presented, we saw the data from New York, which is low compliance or uptake actually in their patient population. There are other parts of the country, though, that have significantly higher usage rates. It does vary across the centers with regards to what providers feel with, because there are some biases with it, but also with patients having to utilize or wear the device. For example, for us in Miami, I always say that if they put a Gucci logo onto the machine, I think our compliance rates or uptake would be significantly higher in our area.
I'll build on that one. This question is, I'll be a sole radiation oncologist in a community hospital. Will it be practical? You actually may have the best opportunity out of the three of us to get patients using Tumor Treating Fields, because you are going to have perhaps a greater degree of control over the care of those patients, and your recommendations will carry more weight. We often have to compete with the interests of other clinical trials and other physician scientists who perhaps have their own agendas. Not saying that those other agendas are wrong, but when there's more competition for available options, you may not have all of the opportunities to enroll a patient on treatment. But when you're the only one, you actually may have a better opportunity to do so.
Great, and I'll just say, regarding that adoption question, the sort of reality is that when the Tumor Treating Fields were first introduced for glioblastoma, it was largely directed towards neuro-oncologists, and neuro-oncologists are used to prescribing medications, but not used to prescribing non-ionizing radiation, which is what Tumor Treating Fields are. What we've seen is a shift towards radiation oncology as the primary prescribers of this treatment. And of course, as radiation oncologists, we're very familiar with the physics of radiation, both ionizing radiation, which we've used for decades, but also non-ionizing radiation, which is what this is. So I think that has a big impact. We better understand the physics of it, as well as the biology. I have a question here asking, why is the cutoff 2 years for glioblastoma patients? That was just a cutoff in the trial. So obviously, when you design a trial, you can't say, I'm going to treat indefinitely. Otherwise, you can't do the data analysis on the trial. You'll never get the trial approved. So the original trial had a 24-month or second recurrence cutoff. However, patients can continue as long as they're willing to do it, and there's, I think, good scientific rationale for indefinite treatment, at least until the patient can't tolerate it anymore. And then there was a question about high number of electrodes or increasing that electrode density, and in fact, there is an ongoing trial looking at that, and that may improve some of those metrics we talked about to increase dose by increasing density. And as the questioner is actually asking, does this increase the degrees of freedom? And it begs to be seen, but that may be true. In other words, give you a little bit more room to move things around. So we'll have to see. The last question I have is what else is there for life-prolonging modalities for glioblastoma? And of course, that's a complex answer. The answer in the approved space, nothing. Unfortunately, other than Tumor Treating Fields, temozolomide and radiation following maximal surgical resection, there is no other treatment that's approved. There are thousands of investigators around the world trying to find additional therapies to build on what we have, and it remains to be seen what will come up next.
I've got one last one. What is the rationale to combine TT Fields and paclitaxel in ovarian cancer as both target microtubule assembly? I don't have the proper preclinical answer for that one, but I'll stab a venture at it. This is the platinum-resistant ovarian population, so they've typically seen one or more rounds of platinum-based chemotherapy. They've seen PARP inhibitors, they've seen Avastin, they've seen probably a clinical trial once or maybe even twice because they're so heavily treated, and weekly Taxol is the last line. And so this was starting from the ground floor in platinum-resistant ovarian cancer, looking at can we improve the response rates compared to the standard of care before patients transition to hospice? And the answer was yes, and now, at least in single-arm study, and now we have randomized data that is maturing, and we will get that answer soon.
Indeed, there are hundreds of preclinical publications talking about the mechanism of action, and my colleagues know well, and it's more than we can cover in this clinical conference, but it's not just microtubules, it's not just mitotic inhibition, it is all sorts of inflammatory response, chromosomal breaks, all sorts of things going on that are a result of tumor treating fields. So I think all of those things contribute to the clinical benefits that we see.
And I would say, I think the adoption will increase as we see approval come across different cancer sites. So I think, glioblastoma has almost been kind of an orphan disease by itself. And then you have now malignant pleural mesothelioma, again, an orphan disease actually truly just by incidence alone. But now if we end up getting positive data in the lung cancer space, and then you have trials that will come out in the hepatocellular carcinoma space, pancreatic cancer space, ovarian cancer space, that will start to pile up very quickly. Mm-hmm. And I think then you will see a change or a shift in the treatment paradigms. Just even at our center, so we opened the LUNAR study, had a kind of a slow accrual to begin with, and then the mesothelioma came approved, again, for non-clinical trial use. And when we were using it in clinical practice, then our thoracic medical oncologists just were comfortable now that their patients were receiving it, and then they started enrolling into the LUNAR study just because of that. They were enrolling more LUNAR patients, then more meso patients came because of that. So everybody was more comfortable with it. So I think you'll see this expand across different disease sites as you see these clinical trials over the next 24 months start to come to a close and start to report out results.
Excellent. Well, I want to, on behalf of my colleagues here at the podium, I want to thank all of you for attending. Of course, remind you to go to the peer review website. You can submit your post-test and evaluations to get your CME credit. The slides and the practice aids, which were linked in throughout the talks, are available for download. And the event was recorded and is available for watching in the next 24 hours and in the online activity area in the coming weeks. So thank you to peer review, and thank you all online and in person. Have a good evening and enjoy the rest of your conference here.